You don't mind if I hum while you're talking, Madeline, do you? That's sort of my strategy.
If you don't mind if I drum while you're talking.
I think you should beatbox, Madeline, while he's talking.
I could just keep shaking my head in disagreement the whole time.
Hand over your face. All right. What time is it?
Let's do it. Let's just do it.
Let's start it. Okay. Well, welcome everyone to another fabulous edition of Friday Chalk Talk. My name is Maureen Blaha. I'm one of the nurse practitioners here at St. Luke's, working on the inpatient side, and I will be your moderator today. And this morning we have a special show for you, a debate on the name Palliative Care versus Supportive Care. Today's presenters are Dr. Martin Mobazelak. He is board certified hospice and palliative medicine and boarded in internal medicine. And we also have Madeline Schmidt. She is Assistant Dean Undergraduate Programs, Clinical Assistant Professor and Option Coordinator, Adult Gerontology Nurse Practitioner Program at Marquette University. So welcome, and I'll let you guys take it away.
Perfect. All right, what we'd like to do before we start is do a pre-debate vote. So everybody who's on right now, I'd like you to open up your chat box and just either write palliative care or supportive care. There's no in between. You can't write unknown. Got to pick one or the other. And I'm going to start my part of the presentation while Maureen goes ahead and tallies those up for us. And we'll find out what the votes were at the end. Ladies and gentlemen of the jury, all of you listening today, you get to decide the outcome of today's debate. And I look really not to persuade you, but to remind you of what you already know to be true. The right choice here is to put aside our pride and our inertia in our emotions and really make the decision that is best for our patients. So in the next 5 minutes, I'm going to focus on points 2 and 3, because we already know that earlier involvement of our specialty benefits everyone, right? We support our patients and their quality of life. We support our colleagues by helping to align their treatment with patient values. And we even support our hospital organizations in fairly pragmatic ways, like shortening length of stay. So let's begin with how the name itself is a barrier. This is a randomized trial from 2013 out of Pittsburgh that looked at cancer clinic patients' perceptions of the name palliative versus supportive care. And patients were randomized to be given a description of either palliative or supportive services, and the descriptions were identical, only the name differed. And those patients were then asked to rate those services on a scale of 0 to 10, and we can see here how just by changing the name alone, it impacted patient perceptions. Supportive care was perceived as better understood, having a more favorable impression, and more likely to be something that they'd want in the future. And there was also an open-ended response to the question, which was, can you please describe in your own words what you think palliative or supportive care is? And we see here that half of the group assigned to palliative care still had no idea, even after reading the description. Only the supportive care group really perceived us for the psychosocial support we do in fact provide. And many more perceived palliative care to be the same as hospice. But names, they impact our medical colleagues as well. And so this is a paper out of MD Anderson. It's a survey of 140 physicians, NPs, and PAs working in oncology. And it assessed their perceptions of the name palliative and supportive care. They asked the question, would I use this service for a patient with symptoms in a new diagnosis, curative treatment, advanced cancer, and end of life? And there was significantly more interest in the service when it was called supportive care. That really only evened out at the end of life, which suggests that by using the name supportive care, we would allow for earlier involvement of our team. And the survey also showed that oncologists perceive the name palliative care as a real barrier to their referrals, that they perceived the name palliative care as synonymous with hospice. And they feared that by using the name, it could decrease hope for their patients and their families. And we already know this, right? We live this every single day. I mean, how many times have we arrived at a room to be greeted by a provider who says, "Oh, you're seeing them," right? And in my career, I have two moments that really stood out to me. First is a hospitalist that told me, "I don't consult palliative care because we don't execute patients at this hospital." And the second is a geriatrician that told me I could never work in palliative care because I need to work in a field that actually gives people hope, right? And these are our colleagues who are going to determine if and when they consult us on their patients. So let's not allow the name to negatively misinform them. And here's my final slide before I hand it over to Madeline. Palliative care programs really have long recognized the impact our name has, and some of them have changed the name as a result. This is a study that comes out of MD Anderson again. And in 2007, they changed their inpatient and outpatient palliative programs to the name supportive care. They did nothing else, no campaign to re-educate, no redefining the terminology, just a name change. And this retrospective study evaluated the impact that name change had on new consults the year before and the year after the name change. On the outpatient side, they found that there were earlier referrals to their clinic, which led to more time with patients in clinic to make an impact. And they had a greater number of earlier stage illness. And on the inpatient side, they actually doubled their inpatient consults just with that name change alone. And when you look overall, their entire system had a growth of 41%. So my argument for you is really a simple one. We know our involvement is beneficial. The name is one barrier. And when that name is changed, we have some evidence to suggest that it leads to greater involvement of our services. There are skeptics out there, and many will point out that these are single center studies or the numbers of them are few. However, I want to focus on how the investment is so small. It's just a name change for a potential of benefit. So I argue we should change the name to supportive care. Madeline, I'll hand the stage over to you.
Okay, thank you. All right, so palliative care. What's in a name? I want to start out by defining palliative care to highlight a few key pieces of this definition. So palliative in its adjective form has a medical definition, relieving pain without dealing with the cause of condition of a medicine or medical care. And I speak to this because we are providers who have gotten education in the medical field, whether we're a doctor, an NP, a nurse. And so we, by just the virtue of the medicine we practice being identified and defined in a medical manner, really highlights that what we're doing is a medical profession. Supportive care is defined as providing encouragement or emotional help. And although we do this as part of relieving, any type of pain, whether it's physical, spiritual, or psychosocial, we also work on the standpoint of the disease and the process and the differences in the medical care that patient is achieving. And I don't think that I feel like that really highlights what we do, and we don't want to lose that as medical providers in this field. I think that, any other term other than a medical term would not really define our medical specialty. And so I think that's an important piece to understand going forward. And if you look at the graphic here, we do all these bubbles, but also the illness piece. And a title like supportive care does not highlight that medical piece of what we do. Secondly, I'd like to highlight the evolution of palliative, why it became what it is today. And It started way back in 1948, which really is very recent, if you really think about it. And they really looked at hospice, started with hospice. And palliative care was actually formed and used to avoid the negative connotations of hospice. And it took like 20 years to figure that part out. But this was providing care holistically to families who were experiencing distress, but also not towards the end of life. So, and then back in 1990, when the palliative care was discovered or recognized as a distinct specialty to improving quality of life and relieving suffering. And then where we are today, palliative care, the prevalence has increased. It continues to increase as a medical specialty. And I think, again, highlighting that we are medical providers that work together to provide this medical specialty piece is really important, and value of the name. So why the resistance? There's not a lot of research out there on keeping palliative care, as you can imagine. And so, a lot of this is anecdotal and is from more of the discussion pieces of research about changing the name. So why the resistance? Providers think there's a misperception of palliative care to patients. They think palliative care means end of life, no hope. Providers are reluctant to have difficult conversations, so they don't, and then palliative care gets involved, and we are seen as the, that end provider. Providers think palliative care is only for end of life, which is really what hospice is for. Providers think that palliative care is only for when all treatments have failed, which is really what hospice is for. And providers, like physicians, like other providers, avoid things they're not good at. So I think, in the understanding of what palliative care does, you can see with the resistance that there are ways to educate rather than sugarcoat the name and still provide the same care, but also in our medical specialty roles. So research that Martin also spoke to found that palliative care is a term as a barrier to referral due to lack of education, not that the services provided were any different. And I think that's really important. Research speaks to palliative care as an intervention that's good from all patients' perspectives. Medicare defines hospice care and palliative care different in terms of coverage, which is important when we're providing both cares. And that's how they define the care that's received under palliative. I don't know what we would do if we changed the name to supportive, how Medicare would, if you bill differently for that. And the reluctance found in research is that palliative care is scary. So when you read these stories, the first thing that I think of is why not be afraid of the disease that's shortening your life, and not the medical team whose whole intent is to give you quality of life, improve symptoms, support, listen to you, talk to your family throughout your illness until you get better or you do not. So, the term palliative care, the only reason to change it is because it scares people. Makes me wonder, well, should we change other terms in medicine? Is this a slippery slope of if we change this, then we shouldn't, we can't call it heart failure because of your heart might, nobody wants to know their heart's failing. So is it the term, or is it how we present our approach to this medicine specialty? So anecdotally, what's the real issue? We're afraid of dying. We can't see past trying to live forever. We don't like the reality that we will eventually die when diagnosed with a life-altering illness. Medical providers who treat illness provide false hope to patients, which only adds the palliative care team into the most hopeless situations and not early in the disease, which then also gives us a bad name bad definition towards what we do. And I really think that if we're discussing the issue of the name, that it's not really the name that scares people as much as it is the illness. And so we need to remind patients of that and really educate both providers and patients. Finally, my proposed solution is to keep the name, start in the education space, for providers, especially oncology, NP schools, PA schools, nursing schools, medical schools. I know we're doing it now, but maybe we're not doing it well enough. Begin synonymous practices with life-altering chronic medicine specialists so it becomes a standard practice. And really team up so that we're doing things all together, just focusing on illness versus symptoms and quality of life. Standardize the definition of palliative care, put it on our business cards on the back so that people know what it is and they can reference it. Provide flyers to patients so that they have a takeaway when they leave about what we're really there for. And approach patients as a team. Maybe focus on, once we're involved, setting up multiple visits. Say, I'm coming today, the social worker will come tomorrow, the chaplain will visit you the next day, and like kind of have a plan so that we're seen as this interdisciplinary team and not, but also a medical piece of it to manage their symptoms and see them holistically. That is my debate. Those are my references.
All right. I'm looking at my notes. So lots of great points there. I think respecting the term itself, respecting the specialty itself, avoiding the sugarcoating, lots of points on educating patients and providers. And I think that's all true. But the important limitation to this is that those changes require other people to change. And so when I listen to palliative care providers that have been in the field for decades, and we have one on our team, Sandy, they talk about experiences and barriers and trying to educate others and facing those same barriers that really have not changed since the very start. And I think it's very hard to get other people to change. I may be early in my medical career, but it seems more and more obvious that systems really change, not because people change, but because those people either retire or they die, right? New people and new ideas take their place. And so here we have something that we can control, right? We can control the name. It doesn't require cost, no time-intensive education. So let's be the one to make the change. Again, put aside the emotion, the inertia, and we'll make the best decision for our patients.
And so I would say, in thinking about our current practice and what we do every day, I do think there would be a cost and it would take a lot of time before people would really recognize that the name change, because historically palliative care has been used for many, many years. But also, I don't think, which agrees with what you're saying, that the current group of physicians that refer to us, if all of a sudden we said, hey, now we're called supportive care, if they would all of a sudden start using us more because we changed our name. I don't, I think, and the research at one hospital is interesting, but maybe we need to do a research study at each individual hospital to find out, is that truly a barrier for those providers, or is it something else? Do those providers just find it, have ingrained in their brain that it's not, it means it's hopeless, and it means they're telling their patients that they're giving up on them. And so, those are some of the things I heard. I just don't think that changing the name means we're going to all of a sudden get earlier referrals. And, I think the experience will be the same for patients, which is what we want. But I don't see that the name change will be the difference.
Thank you, Madeline. That was lovely. Before we open it up for discussion, we would like everybody to go into the chat box again. And you either type supportive or palliative. And Maureen will go in and she'll calculate how things changed. And then once you've done that, please unmute. Share your experiences, your thoughts, your agreements, your disagreements.
I would say from a non-medical provider, the reason I like supportive is especially because with my mom's illness and when she died, I still, and this is my problem, but I still have a problem defining palliative care. And so for the layperson, I would argue for the patients and families, that just hearing the word supportive means something that I don't have to go look up the definition and try to articulate it. So that's, I would argue for, it would actually, it doesn't change the services and the gift of palliative care. It just changes, I think it could change the openness to it.
I was saying, I'm thinking about the number of hours of my life I've wasted trying to explain to people what palliative care is and isn't. And I don't really see much improvement in that, even despite extensive efforts at a national level to try to do opinion polls and marketing research. We're still going to struggle with that. But my concern about, I've been pretty staunch about trying to wave the palliative care flag, but I don't like the word supportive care either. And I think it gets to something else we struggle at. We talk about trying to get earlier palliative referrals, but then we also at some of our sites feel like we're getting overwhelmed with palliative referrals and the patients aren't prepared properly. They don't understand what they're getting. I don't see changing the name to supportive care making any improvement in that problem. And if we're trying to help our patients understand basically get a better handoff from referring people, I think it would get worse if we changed it to supportive care.
Mm-hmm.
Steve, from a medical perspective and like a fellowship and you take boards, and would you be a supportive physician, or how would you describe what you did?
I don't think it matters from a billing perspective necessarily. Our formal credentialing is still hospice and palliative care, or hospice and palliative medicine. That was debated at a national level, and the decision was made not to separate the terms because they're so intertwined in our training. But I think I'm aligning myself more to, there are some programs called advanced illness management, for example, or something along that line, which emphasizes a little more of the medical rigor of the piece, as well as kind of trying to get at some of the more holistic, multidisciplinary care that we try to do. But yeah, I'm exhausted trying to explain to people over and over what palliative care is and isn't. And I do think we have an opportunity, or we're missing an opportunity, to educate our own residents about this better.
I see both sides of the argument for sure. Because I agree with you, Steve, on how defining my role to patients day after day after day is, the struggle is real, right? So it's like every time I go in a room, I have to say, I'm not here to talk about end of life, but certainly we can talk about that. I have to kind of go through it every time, but but I cling to the palliative care because I feel like it's a professionalism thing. And I liked the point that was made that we don't sugarcoat heart failure. So why should we, sugarcoat palliative medicine? And so, your heart's just not doing, it's goes back to the whole, not everybody should win a medal kind of mentality in my world. But
I think most or all of us have been in these conversations before. And as I was trying to say in a long chat before I prematurely hit send, which is my inclination, you both made very compelling arguments and convincing arguments that I've heard before. But as I started to say in my chat, I'm revealing my bias, because I'm not taking sides here, but for Madeline about what's the name, I think we would have, for Steve's comments, we would have at least that many years to try to convince people what supportive care is. And I would almost name it, as you mentioned, and I'm sorry, I'm from your name, 44418.
Maureen, sorry.
Maureen. You mentioned
Call me 9.
I would throw out for thought, and I know we're about out of time, but if I were to pick something that I would not want to be called, it would be oncology. Should oncology change their name to, I don't know, something that kind of hides or obfuscates, this is what we deal with. So again, a great conversation. I appreciate, and again, very well organized thoughts on both sides. So I appreciate being part of this.
Yeah, well done. Thanks, everybody.
Yeah, you guys did a great job. I think one of the things that stuck out for me was what Madeline said, and I actually turned to Alicia and said, we should do a study in my outpatient and cancer clinic about which term is scarier to you, cancer or palliative care, and find out what they say.
Cancer.
I agree with that, Sandy, because I think that instead of asking, are you more scared of palliative or supportive, we should really bring it back to what the issue is. You have a life-altering illness, you have heart failure, you have cancer, you have a brain tumor, you're seeing a neuro-oncologist. And so we should not be the scary ones. They should be afraid of that piece, and we should be the ones that come in and provide that holistic support. And I want them to see that. And I don't know if changing our name, like, hey, we're super supportive, if that changes, getting in there sooner or what we do. So,
but again, great job. Great job.
And along those lines, Madeline, Rose just wanted to say that she's 100% for palliative care. We are already considered a soft service. Supportive care would dilute our image even more. So that's another commentary on that.
Thank you, Rose.
But I think we're close to time here. Thank you, everybody. Well done, Marty. Well done, Madeline. Thank you, guys. And just of note, Vani Coates is on here. Thanks for joining us, Vani.
Have a great weekend, everybody. Toodles.
Bye.